morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to another episode of ACNS webinars. The speaker for the first session of today is our honored guest from Japan, Professor Araki Takashi. Professor Takashi is a professor and director in Division of Traumatology, Department of Emergency Trauma and Critical Care Medicine, Saitama Children's Hospital, Saitama, Japan. He is an important member of various neurosurgical societies, including the Japan Neurosurgical Society, Japan Society of Emergency Medicine, Pediatric Neurosurgery, ISPN, and the Japan Association of Cerebral Resuscitation and Brain Death. He is also a noted author with several publications in various peer-reviewed journals. We are extremely honored to have him today as a speaker at our webinar, and today he'll be talking about diagnosis of brain death and organ donation in children. The speaker for the second session of today is our honored guest from Italy, Professor Federico Nicolosi. Professor Nicolosi is a consultant neurosurgeon in the Humanitas Medical Center, Milan, Italy. His clinical interest is focused on surgery of the skull base and spine. He has special interest in the simulation-based training in neurosurgery. He is the founder of the simulation application, which is Upsurgeon, which has revolutionized the training in neurosurgery around the world. He is a member of the WFNS Young Neurosurgeons Committee. He is also a noted author with several publications in various peer-reviewed journals. We are extremely thankful to him for accepting our invitation to be a speaker at our webinars, and today he will be talking about neuroplasticity and psychomotor skill enhancement, how neurosurgical training is changing. The chair for the first session of today is our distinguished faculty from the USA, Professor Thomas Nakagawa. Professor Nakagawa is a professor at the University of Florida College of Medicine, Jacksonville, Department of Pediatrics, Division of Pediatric Critical Care Medicine. He is also the medical director of the Pediatric Intensive Care at the Wolfson's Children's Hospital, Florida. Dr. Nakagawa is actively involved with issues pertaining to end-of-life care, organ and tissue donation, neurologic and circulatory determination of death, and ethical issues. Dr. Nakagawa has served on numerous national and international organ donation and transplantation committees and expert panels. He is a consultant to medical groups and societies for issues pertaining to pediatric organ and tissue donation and determination of circulatory and neurological death. He has authored numerous articles and book chapters, including pediatric donor management and dosing guidelines utilized by organ procurement organization nationally. He is the lead author of the updated guidelines for determination of brain deaths in children from the Society of Critical Care Medicine, American Academy of Pediatrics, and the Child Neurological Society. We are extremely grateful to him for accepting this invitation to chair the session of Professor Araki Takashi. The chair for the second session of today is our honored guest from Canada, Professor Ashish Kumar. Professor Ashish is an assistant professor in neurosurgery, Center for Cerebrovascular Endovascular Neurosurgery, Sunnybrook Health Sciences Center, University of Toronto, Canada. He was a past fellow with the Fujita Health University as well as the University of Toronto. He is currently the fellowship director of advanced microneurosurgery at his institution and is also the vice chair of the inclusion and diversity division of neurosurgery. He is a part of several novel projects in his institution which are contribution to development of professional practices, education scholars program, and creative professional activity, Sunnybrook Neurovascular Pilot Project, which are aimed to create quality educators as well as quality education in neurosurgery. He won the Peter Boyd Teaching Award for the Best Teacher last year. He is a hybrid neurosurgeon who specializes in the management of aneurysms and other cerebrovascular diseases. He is also a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Federico Nicolosi. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Thomas Nakagawa.
Well, good morning to all my colleagues over in Asia. It's a pleasure for me to be able to chair this session. I want to thank the organizers for inviting me to chair this session and introduce our speaker this morning. It is my distinct honor to introduce Dr. Takashi Araki, who is the Director of Traumatology in the Department of Emergency Medicine, Trauma and Critical Care Medicine at Saitama Medical Center, where he also is a professor with an academic appointment in the Department of Emergency and Critical Care Medicine at Saitama Medical Center and Saitama Medical University. Dr. Araki and I share very much common interests in the determination of neurologic death, but also in the work with abusive head trauma in children that have been physically abused. So with organ donation, child abuse, and determination of neurologic death, our common interests have really brought us together. We've had the opportunity to present at international meetings, and I do hope that one day we'll have the opportunity to meet in person. So it's my great pleasure to welcome our speaker today, Dr. Takashi Araki, who is going to be talking to us about brain death organ donation and child abuse.
Professor Nakagawa, thank you very much for a kind invitation and kind comments. And first of all, I'm very honored to be able to participate in such a prestigious international conference and Asian Congress of Neurological Surgeons. I'd like to thank Dr. Kato for kind invitation to this opportunity, and also appreciate Dr. Raja for thoughtful consideration to prepare for this agenda. And most of all, I'd like to show all of my respect and my appreciation to Dr. Nakagawa for taking the time to chair this meeting for someone like me. I thank you for all of you to join this meeting from the bottom of my heart. Here's a photo which was taken in Nagasaki almost 80 years ago. I believe that the issue of brain death and organ donation in Japanese society faces now also a universal issue when considering the point every single child death is unexpected. And the shock to the parents and the family is immeasurable. Separation from the loving family is the greatest suffering that human being experiences. The concept of brain death brought about the modern intensive care is also an avoidable ethical issue in medicine, as it is the foundation supporting organ transplantation. And today I will take a little bit about time. I'll talk about the pediatric brain death and organ donation, with a particular focusing on the introduction and the historical background of the system in Japan, as well as its program. Here is a case of a 4-year-old child who was involved in a car accident and underwent the craniotomy for evacuation of hematoma. Immediately after the dural incision is made, as you can see, the brain swelling progresses and so rapidly that even closing the wound is not easy. This child could not be saved. So I'd say neurosurgeons have been trained to go through and mature through such excruciating experiences. The brain determination is the evaluation of these limitation of treatment. So we routinely perform the brain determination for infants for the purpose of medically evaluating limits of treatment. Of course, we also share our infrequent clinical experience in determination of the brain death with the young neurosurgeons. Here's a photo with the family of the young boy made the decision to donate organs when the beloved child was brain dead from severe brain damage in a car accident. So for a child who has grown up with the love and affection of his parents and siblings, it's not easy for the parents to understand in a very short of time he's in a very serious condition, and to calmly express their wish to donate his organs. We fully supported the parents in their decision and did our best to fulfill their precious wish, which was broadcast nationwide as a TV program. This was easier said than done. I'm sure you are all aware of the historic achievement Dr. Nakagawa in fundamentally revising the criteria for determination pediatric brain death in the United States. The United States has been a pioneer in the history of brain death and organ donation. But although the Harvard criteria were established in 1968, establishment of pediatric criteria was delayed until 1987. And since the many points have been raised, including the need to establish age-specific criteria, low sensitivity of ancillary tests, the problem of chronic brain death, the poor quality of brain determination. But we believe that Dr. Nakagawa's 2011 revision of the criteria to more precise content was an important change in the history of diagnosis of brain death in children. Since the criteria of determination of the brain death in Japan have been legislated, the descriptions in the manual are legally binding. So all medical facilities must have this booklet and must perform the determination exactly the same way as described in this booklet. And there are significant reasons for this. So I will discuss one medical dispute that has caused this. Quickly summarize the medical distrust in 1968 called as water case. It was the first heart transplantation case in Japan and 30th case in the world. And the first couple of weeks, the recipient progress has been pretty stable. Immediately after the surgery, this news was reported enthusiastically all over the nation. They described it even as a medical triumph. However, they changed their attitude quickly once the recipient, Miyazaki, passed away, unfortunately, POD 83 because of multiple organ failure. The media started to try to find the fault, Wada's surgical performance. Most negative part of this story was that retrospective inspection to this incident was totally neglected, whether heart was removed from the patient who was not brain dead and transplanted organs into a recipient who was not sick enough to receive a graft. Dr. Wada, cardiac surgeon, declared the brain death of a possible candidate for organ donor, Yamaguchi. As soon as the brain death was declared, Wada and Yamaguchi sent Yamaguchi to the OR without explaining about his condition to his family, and his heart was taken by Wada as well. Finally, Wada was charged with murder of both young men. And also, eventually, the responsible pathologist for this case was convinced that the heart was he was given to examine, suppose Miyazaki's, either or not original heart or less had been tampered with. The fact has never been revealed. Then public furor over the Wada case, focusing on the possible mother of the donor. This picture was appeared on the major newspaper of Japan. Wada was standing behind the donor's family as if he seems to make a direction to them. On both sides, the recipient family members were set. For some reason, charges were dropped 1972 after the expert testimony was completed. Many Japanese citizens believe that Wada case has caused a great deal of distrust in medical care. As a result, organ transplantation in Japan has totally stalled. Even now, I myself sometimes wish to get to the bottom of the matter. This dubious lesson has led to the implementation of the system in which brain death diagnosis and organ transplant, organ donation in Japan must undergo rigorous post-mortem review under the restriction of the law. In Japan, the criteria of determination of brain death are called legal criteria because they are legally binding. There is no major difference in context compared to the global standard. But in the case of pediatric patients, there is a unique clause that prohibits organ donation from abused children, which will be discussed later. The criteria for determination of brain death in children are compiled at the same time. Committee was established in 1999 and published in 2000. However, the Japan Pediatric Society's strong opposition subsequently put a stop to the diagnosis of brain death in children. As a result, the road to organ transplantation was completely blocked. The law was finally amended in 2009 by imposing a backward-looking condition prohibiting organ donations from abused children. And the next year, 2010, organ donation from children under 6 years of age finally became possible. However, the main reason for the lack of progress in organ donation in Japan is that brain death is completely limited compared to the other countries. Let me explain about this. Including my experience in Toronto, I have learned the progress of determination death in this frame. The diagnosis of brain death is playing a very important role for drawing the line limitation of the treatment. In the US, based on the UDDA, brain death is a human death, so responsible physicians can declare the death of the patient at this point. On the other hand, how does the significance of brain death be considered in Japan? Because enough inspection to that distrusted event was not accomplished, social trust towards the brain test has not been provided yet. Therefore, the doctor's discretion of declaration of death by neurologic criteria is legalized in the area surrounded by red square. A further challenge to overcome is the poor quality of brain test determination in children, which was extremely shocking in the 2000 study. Of the 139 patients whose family were informed of the diagnosis of brain death, only 14% fulfilled all criteria. This was a major bioethical issue and became a social problem. Very interestingly, all of the brainstem reflexes, the implementation rate in certain judgment was extremely low. The reason for this is unknown, but it is clear that implementation rate is very low for these three reflexes. However, we found that this phenomenon is not unique to Japan. A study from Southern California reports that here is a report regarding the variability in pediatric brain death determination. 51% of the children who was diagnosed with brain death became organ donor, but 60% of the brain death was determined without apnea testing. Moreover, in 2013, Chappelle reported a sensational paper regarding the practice variability in the brain death diagnosis based on the 226 brain death organ donors. 41% of total brain death diagnosis was incomplete. So what is thought on this? Do you think they're fulfilling their missions under these circumstances? I would say I don't think so. If we are going to declare a child brain dead and remove the organ from his or her body, I believe that these kinds of improper medical judgment must be corrected as soon as possible. Another major issue related to pediatric brain death is recognition of long-term survival after the diagnosis of brain death, a concept that Alan Schumann has long advocated. He believes that the reason for this is a question of whether there are pediatric patients who have at least some degree of continued bodily integrity even after the diagnosis of brain death. This controversial issue has also caused apparent confusion in clinical practice and also between family understanding and medical judgment regarding brain death. In fact, the detail of brain death diagnosis were apparently up for debate. With cultural diversity, there will continue to be families who do not recognize brain death as a human death. Only New Jersey and New York have state laws and have taken into account religious and family wishes in death decision in the United States. So as you may know that the Jahai was pronounced dead in California and moved to New Jersey and passed away 5 months later due to multiple organ failure. Then with the development of electrophysiological evaluation method and diagnostic imaging, pathophysiology of the brain dysfunction with these questions has been clarified in ways that were not previously understood. And the interpretation of the concept of brain death has been forced to change as the intensive care made it possible to maintain respiratory circulation for long periods of time. What will the diagnosis of the brain death really mean in the future? Because these philosophical and ethical considerations are sometimes critical and sometimes metaphysical, but they do not provide a clear indicator for real clinical decisions. But I personally believe that they may play a very stimulating and thought-provoking role in anthropology. Previously, there was also a history of vocabulary brain death itself being called into question in the government-led white paper. Government white paper called for the term brain death to be replaced by the term total brain failure. This the debate to resolve this confusion in clinical practice may be provoked again in the future. Here is a model proposed by my mentor, Dr. Shimizu, a great scholar of bioethics, is that acute medical information must be provided in order to form a consensus based on the strong trust between the healthcare professionals and the patients and the families regarding all medical treatment. If the medical information is inaccurate, it will be accused of inducing biased intention towards the organ harvesting for organ transplantation. It is believed that the brain death diagnosis must be accurate. So to gain the trust of the society towards the diagnosis of brain death, the verification document format has been used in our country to verify the brain death diagnosis made at time organ donation was medically appropriate and fair, all stages of the process. And in all cases of organ donation under the brain death so far, it was proven that proper determination was performed since 1998. My research team then visited the 10 facilities that agreed to participate in this study, an interview about how brain death donation was actually performed. Recorded data was converted into verbatim, and through the categorization, factors that made people hesitate to donate organs and the factors made organ donation possible were organized and analyzed. This categorization was symmetrical, distinguished between the factors that made the people hesitate to donate organs and those that made organ donation possible. Factors that caused hesitation included, number one, inadequate system for organ donation at the medical facilities, and number two, lack of understanding of the organ donation system. Number three, family background problems. Number four, difficulty in excluding child abuse. And number five, instability of the condition itself. In contrast, the factors that made the organ donation possible included, number one, family's strong desire for organ donation. And number two, hospital's ability to respond to that situation. Number three, proficiency in the abuse diagnosis. And number four, meticulous family care. Then in analysis of the PICU data, determining which pediatric patients are more likely to be eligible for a diagnosis of brain death, we found that 83 deaths over a 5 years period, patients with more severe brain dysfunction had a significantly shorter time between admission and decision to limit treatment. After all, brain injury due to central nervous system disease tend to be a candidate for brain death diagnosis. It is an extremely regrettable for the fact that despite the child families expressed willingness to donate their beloved child's organ, Japanese system refuses to accept the previous organ donation offer for many reasons that require an unusually careful and rigorous brain death diagnosis. It must be said that the state of affairs is no longer an exaggeration to say that this society is dysfunctional. One of the reasons for this is the clause, that law that prohibits organ donation from abused children. I will present, and this is a busy slide, I'm sorry, but I will present an example of organ donor who went cardiopulmonary arrest to brain death indoors without the presence of a third party. This facility collaborated with the police and independently determined there was no criminality, such as murder by abuse, and practiced organ donation. But on the other hand, this is an example of organ donation who was not carried out due to the system for the elimination of the abused children. Despite having the exact same patient background as those admitted to the aforementioned facility, organ donation was abandoned because the in-house organ transplant coordinator placed undue importance of legal provisions, and the facilities did not make a clear decision regarding the possibility of due to child abuse deaths. However, Japan is the only country in the world that prohibits organ donation from the abused children. The Japan Pediatric Society was a strong advocate for the enactment of this law. And its 2010 statement, it provides a reason why the donation from the abused children is prohibited, and it says, protection of the human rights and dignity of the donor child is fundamental. However, I wonder if this includes that the human rights and dignity of the children suffering from the heart failure, whose lives are to be saved by receiving a heart transplant. This is a flowchart, the abuse exclusion created by this Japanese Pediatric Society. It seems to take a lot of effort and time to go through all of these barriers. This is why there is no end to the numbers of cases which organ donation has to be abandoned. I have the impression that the overly complicated system have been created by the forces that potentially oppose to the organ donation. This year, our research group has finally started fundamental revision of this system. I also interviewed the pediatric neurosurgical authorities around the world regarding organ donation from the abused children and asking their opinions. Professor Rutka of the University of Toronto stating following, I did not see the word accidental injury prohibit the organ donation from being because of the requirement of the further medical legal investigation. And also Dr. Yu Huan, pediatric neurosurgeon, Massachusetts General Hospital, who is world renowned for her historic work on abusive head trauma research, said, organ donation in children who are victims in child abuse, your point out is a controversial issue, but this situation is very unusual. Also, I asked Dr. Figarji Cape Town, who is one of the world leading experts in the intensive care of pediatric traumatic brain injury, stated that there is no reason to prohibit the organ donation from abused children. So why is it so difficult for human being to easily correct an action once initiated and make it what it should be, even if they are aware that it is an absolute mistake? The daily news reports are also heartbreaking. We have already learned from our ancestors that by quickly stopping what needs to be stopped now, human society will once again flourish and bring about a better society. I also believe that we human beings must have the compassion to understand the heartache of this kind of boy carrying his brother who has lost his life in Nagasaki, waits for his brother's funeral. For the past 10 years, I've been working to develop an educational opportunity for pediatric healthcare providers so that they can accurately diagnose the various remaining issues of brain death in the light of modern internal medical standards, explain the conditions of the family with compassion, share the suffering, and realize organ donation based on trust through empathy. Effectiveness of this simulation training has been subject to the paper, but it's based on a lecture and a practical exercise using a simulator. This is an image of the participant checking the brainstem reflexes. This is a view of the lecture apnea testing. It's been well received as a very effective educational session. This is a hands-on exercise to learn electrode placement for highly sensitivity EEG. Students learn how to remove the noise using instructor's own. Here we will provide the training on the treatment language that healthcare professionals should pay attention to when telling the family bad news brain death, as well as the empathy for the health, heartache, and psychological effect. Finally, lecture on the basis of diagnosis of abused children will be given. Before and after this training, quiz will be given to evaluate the learning effect. We believe that after the training, effects will be objectively recognized. Finally, physicians, nurses, and other professionals will be divided into groups for general discussion using scenarios to consider how to take countermeasures for the simulated cases. Here is a sample of discussion sheet. Individual opinion will be summarized in this format like this. We have compiled 10 years experience and recently published this organ donation handbook, adult and pediatric editions written in Japanese, but we expect that the result of this work will only be tested in the future. And last month, Professor Gupta hosted an international conference in New Delhi, where I had the opportunity to explain the more detail of these educational materials. And also textbook Brain Death Organ Donation in the World has just been published. Of course, Dr. Nakagawa's excellent and the detailed description of the pediatric brain death is also included in this book. So I hope that the interested neurosurgeon will take a look at this. So last but not least, this photo shows Hiroshima taken in 1955, 10 years after the end of the war. On the left, the atomic bomb dome registered as a World Heritage Site is presented. The surrounding area, which had been burnt field, has been rebuilt. And if you look closely, you can see that many stores and people standing in the Peace Park, thanks to the silent effort of many people and their enthusiasm for reconstruction. Hiroshima has now been rebuilt as a city of 1 million people. I believe that the history of transplant medicine in Japan is a history of hardship, requiring exactly as much time as recovery from the ruins of Hiroshima, involving the many people and having to re-earn the trust of the society once again. Even though we have lost all the memories, the happy time, and in the depths would disappear, if we persevere in our pursuit of ideals and never lose hope, there will surely come a time when the light will shine. My mother, who was exposed to the atomic bomb when she was 8 years old, 3 kilometers south of this hypocenter, said these words as a lesson to me from my childhood. I'd like to conclude my story with my sincere wish that a definite solution will be brought to the issues of brain death and organ donation for children, and that peace will come to the world as soon as possible. And thank you very much for your attention.
It's an excellent presentation, Dr. Araki. I believe that we'll take questions from the audience at some point, but I'll lead this off by saying in the United States last year in 2021, we had 922 pediatric donors. Of those, there were 713 brain dead donors and 209 pediatric DCD donors. And a number of those children were actually victims of abusive trauma. And I've talked about this at the National Shaken Baby conferences through multiple years. The National Association of Medical Examiners in the United States actually has a policy statement. And our system's a little different from Japan because we do have medical examiner and coroners, but they've really made an effort to have zero denials for organ donation because we still have about 150 people in the United States on an annual basis where medical examiners actually rule out donation. And that results in anywhere from 400 to 600 organs being lost for potential transplant. And when we have a list of 116,000 people, that's a significant number of organs that we're looking at. I'm curious, what are the efforts in Japan to try and move forward with working with your investigators and your medical societies to allow abused children to become organ donors if they die?
Thank you for asking one great question. Actually, we have been discussing how we can put this very difficult problem forward for a couple of times with the several authorities of Society of Neurological Surgeons or Society of Pediatrics number of times. But unfortunately, the law has not been revised at this time. It was unfortunate to say that we are not able to revise the law itself. The difficult part is that all the process was legislated. So then, and this is not that only the medical discussion, not only a medical discussion as well as the, but also the politics. So then we really like to focusing on the revising these parts of this law, but our power is quite limited, so that we are not able to change everything in a very short period of time. But probably we may have to invite the authorities of determination of brain death or this system itself from all over the world, like Dr. Nakagawa or like other countries' authorities, and get together and ask you guys, give us some recommendation or advices to invent this very complicated system, I'd say.
There are a lot of moving parts. And in the United States, we work very close with our forensic team in the hospital, which are child abuse specialists, because they help us make that determination of suspicion for non-accidental trauma. We also have to work very closely with our medical examiner, coroner, and our investigators. And the important thing is getting them involved early, because if you don't, then evidence is lost. And I know that people always talk about the fear of losing evidence, but these children are typically in the hospital for several days. And if you don't get that evidence on the first day, it's probably gone, because in the world that we live in pediatrics, the first thing that a pediatric nurse is going to do is bathe and clean up that child, right? And once they do that, a lot of your evidence is lost. So are there other questions from participants?
We can take questions. Yes, Professor Takashi Kon has joined us from Showa University.
Yeah, yeah. Thank you, Dr. Raki, for a wonderful lecture. I'm Dr. Takashi Kon in Tokyo, Japan, and also encounter such pediatric head injured people, the potential organ donor sometimes, but they are also due to abuse or suicide or due to school bullying, some appalling cases. So we have to observe that patients. But even in Japan, foreign country, children from foreign country will encounter such kind of situations. I appreciate, I respect your, in your difficult situation, you established the medical legal and tackling with medical legal problems and sometimes some criteria established. So I appreciate and the future work. So collaborate with your JOT or your you collaborate with you, and we prepare for the organ transplantation system and establish if we encounter such patient. Thank you for the lecture.
Thank you very much. This is my co-host, Dr. Libun Singh.
Thanks, Raja. Thanks, Prof, for a very extensive talk on pediatric brain death. I have a few questions for you, Professor. What's your opinion regarding the use of CT angiogram as one of the tools in determining brain death in pediatric? Are they useful or not useful? My second question, Professor, regarding patient on a long-term barbituric coma, how do you determine the cessation of the effect of the drug before you do a brain death test, and then how are that you would that affect the study of EEG, for example, and when do you do the EEG in those patients? My last question, Professor, is there that in your study any correlation between intracranial pressure or intracranial ICP brainwave with determination of brain death, and do you come across any brain marker to indicate total brain failure? Thank you, Professor.
Thank you for asking me wonderful questions. For question number one, in our country's legislated criteria for brain determination, we have to use that the high sensitive, five-fold sensitivity of EEG. So the electrophysiological silence needs to be required to determine the brain death. So then another ancillary test will be can be used. For example, evoked potential for brainstem. ABR, audio auditory revoked potential is also useful. And the second question is I couldn't get that quite detailed of your question because of the the failure of the
patient on barbituric coma. Barbituric. Yes. How do you determine that the drug no more affect the brain test and the EEG?
Okay. 48 hours needs to be passed when they cease the continuous infusion of the barbiturate. We have to wait for at least that 48 hours, and that's the determination. And another one is that the ICP monitor. We usually routinely use the ICP monitor when the patient's GCS is lower than 8 or less 8. We usually use the ICP, but we haven't used the ICP value itself to determine the brain death or not. So then, just for let's say research interest, or maybe zero findings, zero value will be, we can say something. If you saw that the ICP value is 0 or CP value is 0, we can say something. But it is not included into the criteria for determination of brain death in our country.
Thank you, Professor.
You know, in the United States, the pediatric brain death guidelines, the two accepted ancillary studies are EEG, which is solely falling out of favor because we recognize that death is really a circulatory function, not an electrical phenomenon, and cerebral blood flow studies. CT angio has not been approved in children. And I think it's important to understand that the cranial vault dynamics change based upon the age of the child. So for instance, an infant with open fontanelle or a patient with decompression craniotomy will not mount that increased intracranial pressure that you may see in a closed cranial vault. And therefore you may actually have regional perfusion. So we really do stress the fact that determination of neurologic death in the United States is really a clinical entity. There are occasions where we do have to use ancillary studies, and most people have really moved towards using cerebral blood flow studies in children, cerebral blood flow study, or transcranial Doppler in adults. But CT angio has not been accepted, nor has MRI for an ancillary study per se, and we don't rely on brainstem audio evoked potentials either. So we're very limited in what we have available to us as far as ancillary studies. For barbiturate coma, you know, we recommend waiting at least 4 to 5 half-lives of that drug. And unfortunately, the barbiturates have a very long half-life. And so we do rely on flow studies to assist us in those cases.
Thank you very much. We have Ben from Hong Kong. My dear friend Ben, any questions from you?
Yes, thank you, Roger, for the introduction. I'm Ben from Hong Kong, a young neurosurgeon. So thank you for your lecture. It's a very quick sharing of the situation in Japan. May I ask, I have 2 questions. The first one is who can certify brain death in pediatrics in Japan? Is it a pediatrics intensivist or a neurosurgeon, or specifically a pediatric neurosurgeon? And how many, the second question is how many sets of brainstem death tests you need to perform? Is it still the two sets of the brainstem death tests? And how, and for pediatric cases, how much time you need to perform in between these 2 sets? Thank you.
Thank you for asking me questions. And for certified physicians to determine the brain death in Japan, emergency physician, first of all, emergency physician, and a neurosurgeon, and the intensivist, and the pediatrician. It can be diagnosed, can diagnose the brain death legally. And another question is, when the patient age is younger than 6 years of age, interval time will be 24 hours. When the age is older than 6 years old, the interval time is at least we have to wait 6 hours. So this is a little bit different from the other global standard, maybe. Our country's determination criteria is a little bit more, I say, divided, too divided. But that's our country's system. Thank you.
I see. May I also ask the panel, since there is ancillary testing concerning the cerebral blood flow with the angiogram, how about the radioleuculi scan? Would you consider it in your daily basis as well?
No, actually, we haven't used those methods to diagnose the brain death. So like as the Dr. Nakagawa mentioned previously, that basically the brain death diagnosis is a physical diagnosis. So then based on the physical phenomenon. So then obviously the or other methods to evaluate cerebral circulation or other physiological electrophysiological activities. There are numbers of examination of studies, method of studies be there, but unfortunately in our countries we just only use the physical phenomenon plus the five-fold high sensitivity EEG test.
Thank you so much. And indeed, it's a great sharing on your situation, on the situation in Japan. Thank you so much.
Thank you very much, Ben.
Yeah, well, you guys are like I'm very for your patience to my I'm not really good at English, so then thank you very much for your patience, very patient for your convenience. Thank you.
We understand. Thank you very much, Professor Takashi. We have Professor Nicolosi as well as Professor Ashish Kumar. We can take their comments, the situation in Italy as well as in Canada. Welcome, Professor. Any comments from you?
Thank you very much. I have been impressed by the topic. Is quite. I'm not a pediatric neurosurgeon, and situation in Japan is just, I mean, the tip of an iceberg, because I mean the same problem is in any country, and let's say that here the situation is quite different, because I mean donation is the regulation is complicated as well as in your country, so it's a very hot topic, and so I have no questions, just a comment, a very interesting overview. Thank you very much, because it's a very impactful topic, and it is one of the topics that you listen to not only as a neurosurgeon but as a human being. I mean, as a father in my case, and it's very impactful. So thank you very much for your very valuable talk.
Thank you very much, Professor Ashish Kumar.
Thank you so much, Professor Takashi. I think your English was superb. I didn't have any problems understanding what you were talking about. So very, very, elaborately explained. I hear, because again, the same thing, like I'm not a pediatric neurosurgeon, and there is a separate pediatric hospital in the city, hospital for sick kids. So all the pediatric patients, they actually go there. So I also don't have a first-hand knowledge about brain death in pediatric patients. But again, for adults, as Professor Nakagawa mentioned, we rely on the flow studies as well. So I'm not sure how that will happen in pediatric patients, but I was amazed with the kind of simulation exercises which you were teaching to your residents. So I'll have just one question in regards to that. Like, do you train your residents in declaring brain death, or it is for medical students? Because here in like especially here in Toronto, I don't think so we have any simulated exercises for neurosurgical residents to declare brain death. Of course, ICU is a major part of doing that exercise, but I'm not sure our residents are like trained in simulation like I saw what you do in Japan. So can you elaborate how you plan those simulation exercises?
Thank you very much for asking me a wonderful question. Actually, I did a clinical fellowship at the Sick Kids Hospital from the 2001 to the 2005 under the supervision of Dr. Ruka. So I really appreciate your department. Thank you very much. And actually, regarding the simulation training, we always call the general pediatrician to take part in this simulation training course. Because as you may know that this occurrence rate, I mean, instance of the brain death among the pediatric patients, and the rate is very infrequent. So then it is a very rare occasion. If you want to, some of the residents or pediatricians involved in diagnosing brain death in practice. So then simulating training course is the most effective way, I believe. So then I usually call the pediatrician and then take a look at, simply take a look at this training course. It is very interesting. And then if they want to join that meeting, I'm more humbly welcome all of them. And then we try to emphasize them to think about the concept of brain death or bioethical issues or those stuffs. Thank you.
It's a fascinating topic because this goes back to, I think, a lot of what we're doing with training today, whether it's neurosurgical training or critical care training. Residents don't get to do the number, or fellows don't get to do the number of procedures like we used to, many years ago. I mean, looking back over 35 years and participating in probably at least 8 to 10 brain death examinations per year, many fellows are coming out of training now and probably only participating in a handful of brain death examinations. Now in the United States, we're very specific about who can determine or make the determination of neurologic death, but it does have to be an attending. And we do encourage fellows, extenders, advanced practice providers, residents, medical students to observe and to participate in that. But the actual certification has to be done by an attending. And I think that's very different from our adult colleagues elsewhere.
Thank you very much. There is one question which has been popped up on the chat box, and he is asking, Professor Kishore Kumar asks, how do you explain some jerky movements, spinal reflex after brain death to a patient's family? They will ask he is having some movement of limbs. Thank you. How can we answer that?
I believe this is a very hardest question to answer among all the questions. From not only the medical doctors, but also the families themselves. I personally believe that we should be very honest enough to tell them what's going on inside the brain by showing the result of the. I believe that the result of ABR is very useful to let them know that what's going on. Actually, in the brain is not functioning anymore. To showing that the flat line, just only flat line, and so put another normal result was here. We can compare both of them, and then let them know that what's going on, what happened, what had occurred inside the brain. So then, my personal belief is that try to be always honest to let them know that actual result, show them the result as it is, and then let them think that are you believing this result or not, and then let them answer to my question, and then try to communicate each other so that we can make a mutual understanding very firmly. So that's the first step of my making a mutual trust when we think about the brain death or family care or bioethical issues. This is my answering to that question. Thank you.
Thank you very much. We are out of time, so I apologize, Ben. We will go to the second session. Before that, we'll take the expert comments from Professor Thomas Nakagawa before we wind up this session. Your concluding remarks, Professor.
I think this is it's a fascinating topic. Death by neurologic criteria is really that final common pathway, whether it's circulatory death from somebody who dies after you remove technologic support. It's all related to flow to the brain. And I think that what will happen and what we'll see over the course of the next probably 5 to 10 years is that everything will move to flow studies. It's not electrical activity. This is very much like what we see in circulatory death. If you ask your colleagues, when is somebody dead? If you extubate somebody and you see electrical activity with no pulse pressure, the patient is dead. Life is dependent upon circulation, not electrical activity. Electrical activity just shows you that there are some cells that may be firing, but they don't really result in function of that organ. And so I think eventually we will move to an entire flow-based death, a single death, which will be, loss of circulation to the brain in all circumstances results in death. So wonderful talk, Dr. Araki. Always good to listen to you. I do hope that one day we'll have the opportunity to actually meet in person.
Yeah, definitely.
Thank you for allowing me to chair this session.
Thank you very much. We had a very wonderful discussion and we learned a lot from both the speakers and chairs. Thank you very much. I would like to mention that this is being broadcasted on WeChat, YouTube and Zoom, and as of now we have around 540 participants who have joined us live. So now it's time to move on to the second session. So I'll hand it over to Professor Ashish Kumar, who will say a short introduction, and invite Professor Nicolosi.
Thank you, Dr. Raja. This topic of neuroplasticity and simulation for training for psychomotor skills is very close to me because, as you know, I think we had a webinar last month, and I presented on surgical neuroanatomy training, and simulation was a major part of it. And I am an endovascular surgeon, and of course we have a lot of simulators for endovascular techniques and for skills. But usually, because I'm a clinician educator, I have a soft corner for training, and I think this is picking up across the globe now. And we now see a lot of conferences, keeping a separate slot for hands-on training. In terms of endovascular simulation, I think it's very, very common now. I think I've seen this when I was in India, and I've seen this when I'm here. There are a lot of hands-on training models for endovascular simulation. Now, as regards to open vascular skull-based approaches, I think we have only reached up to the cadaveric dissection because we think that that's the best modality to train on for residents, and it is the best modality. The problem with that is we don't get it, readily. We don't have significant access to it, and the access is also depends on if you have a anatomy department in your lab, what kind of practice you are doing. Are you in an academic practice or you are a private practitioner? So a lot of factors come into play when we are talking about simulation. While training for simulation for residents, I think they have a little bit easy access because they are obviously training in a postgraduate institute where they will usually have a backup anatomical department, for providing the cadavers. But now comes the 2022. We have options for simulation for like upsurgeon where you can have conferences, you can have these dedicated sessions, and you don't need an anatomy lab to support you. So for example, if there's a surgeon who's practicing somewhere remotely, all he needs is the loops and the instruments and the box model, which Professor Nichols is going to talk about. Because I actually reached out to the upsurgeon team last month, and we had a discussion regarding how to procure, how to organize a simulation lab, and it was an interesting discussion. And I mean, they presented, and I saw what they are doing in this era, and add to that virtual reality, and then they combine both virtual reality as well as their models to train on, and you don't need much of a backup support. You don't need a lot of, even you don't need microscope. Of course, microscope will help, but I think the way they provide that, it's very, very useful for young residents wherever they are practicing, and they don't need that academic support as well. So I think simulation is the way to go for training, especially in cerebrovascular surgery, where the training road is quite steep. I think in that situation, these simulation models will help a lot of young neurosurgeons and as well as residents. And I'm pretty sure we are having a conference in September where we are using upsurgeon models for open vascular training, and of course there are endovascular simulators as well. So I think this is a very, very interesting and upcoming topic. And I think it will be very, very useful and a game changer for residents across the world. I would like to thank Dr. Nicolsi for taking up this initiative. It's not easy to start something like this and arrange so many conferences across the world, and now making it accessible to residents without needing a lot of technical support. So I think once we hear your talk, people will be very interested, and those models are also not expensive. So I think they will be very much interested in getting these models for their conferences wherever they are organizing. And individual neurosurgeons can also order them and practice microvascular anastomosis approaches, cranial approaches. I think that will be very, very useful. So I invite you to talk about simulation and psychomotor skills training for residents. And thank you so much for starting this initiative, Professor Nicolsi.
Thank you very much, Dr. Kumar, for your kind introduction. Thank you very much. And thank you to the organizers of this wonderful event. I've been very honored to receive your invitation, and I am very happy to do this talk. Thank you also to the previous Dr. Araki Takashi for the impressive talk about a very important topic. So I absolutely dramatically change topic with my presentation. So I will talk about education and training and technology. Thanks for introduction again. I want to move the focus from the simulation to the mindset, because neurosurgery, as any surgical discipline, is very conservative. So we need to be ready to challenge the status quo. If we consider that we, for many years, we trained people on cadavers, and now we say we may use technology not to replace cadaver, but to reinforce education. This needs, let's say, a new mindset. It's not easy to accept for many generations, but this is the reality. We have a lot of technology and we can improve education. So when I talk about neuroplasticity, I talk about how to change the way we teach and also learn. So, and this is possible. We can influence people, we can influence training, and we can change the learning curves. When I talk about psychomotor skill training, I refer to a mental training and a manual training. To do neurosurgery, we need a lot of mental skills, which are not natural skills. And to do also the surgery, we need to train people on very sophisticated movements and very sophisticated automatism. So it is an overall changing of your mind and on your hand. Obviously, I will talk about my experience as founder of Upsurgeon. And we started absolutely from the beginning. So we started analyzing what we do. We need these super skills to do neurosurgery with good results. And generally, anything can be done without exercise. So when we talk about surgery, we talk about exercises. And when we talk about exercises, we talk about repeating something on cadavers or patients. So if we do errors on patients. So this is the problem today. To do the daily practice, we need to have access to the OR, access to the patients, and sometimes also we may have access to cadaver. I say sometimes because this is a very important topics. The access to cadaver is very limited around the globe. So the reality is that during our residency, during our period of training, and by the way, we continue training also after the residency, what happened is that we train in a random way. This is how we train, is a figurative explanation. I mean, we every day access randomly to the OR. If you take 15 residents of the same school, at the end of the period, at the end of the cycle of residency, they received very different experiences. They did very different chances. So we train in a very random way. It means that at the end of the cycle, they will be completely different one from another. And probably the 50–60% of the procedures will be something new for them. So this is not acceptable today. What we need to do is to challenge the tradition, and we need to create new ways to improve, not to replace the tradition, to improve the tradition. So when we talk about training of the new generation, many times many observers or when we talk, say during the conversation, but we cannot replace the cadaver. We are not talking about replacing the cadaver. We are talking about filling the gap between a cadaver lab and another. And in many places where cadaver is not accessible, we are talking about creating the base for education, which is not only theoretical. We need to try and we need to have errors. So we started with a group of research in 2015 analyzing mental skills and manual skills. As you know, we need special skills on both sides. So it's not just virtual reality, it's not just physical, we need both. We need to improve our abilities in any sense. And by the way, this is not my idea, this is the literature which is coming out. So many universities, this is an example, are defining, and as Dr. Kumar said, there is a lot of potential in education and in training and using simulation, and in many other disciplines, this is already a must. So in neurosurgery, let's say we are delaying in applying this in a systematic way, but we are running on this. And what I'm talking about is augmenting skills, and this is absolutely possible. It's not, let's say the tradition says to become a neurosurgeon, you need a special human being. It's not true. You just need to love what you do and you need to dedicate yourself to what you do. And this is important for young generation to think that to clip an aneurysm, you need to have some, I don't know which specific skill. You just need to train. You just need to do errors and train every day. So augmentation means dedicating time every day to something, but I cannot do this every day on patients. So we need an alternative to maintain a daily basis training. What I'm talking about is to look at the future of certification in neurosurgery. It is not just theoretical. We cannot accept to certify people without really knowing if they are able to do things or not. We need to try to create a base of practice. And also using simulation, we may evaluate people, we may certify people. So we are working on validation to have obviously a base of scientific literature to say that simulation can certify abilities. And by the way, in many disciplines, this already exists. Let's say the traditional example is in the aviation. So the pilots do simulation to be certified. I will do another example. This is an example of DARPA, which is a defense program of US. And in these kind of programs, there is a basis of literature already supporting the idea that targeting the neuroplasticity with special trainings can create new skills, can improve new skills. I mean, special skills. And a neurosurgeon has special skills because are very different than from what we do every day in the rest of our activities. So the creating a targeted neuroplasticity training in neurosurgery is absolutely possible, and this is what we are doing actually. You know very well the problem. I will be fast here, but just to sum up, in many countries, there is a huge gap, there is a huge lack of safe surgeries, there is a huge gap of numbers. So 23,000 neurosurgeons needed around the globe. And in many other countries, it's not just a problem of quantity, it's also a problem of quality, because our residents spend 15 years to become autonomous in 40–50% of the procedures, many times less than this, to become autonomous in specific topics. And obviously malpractice is related with this. So it is also an economical problem, an healthcare system problem. So what we need for low cost, we need global dissemination, we need simulation-based certification. I will start from my personal experience. I was a resident in 2015. I started with a group of other residents and our professors talking about skull-based surgeons, and we started applying simulation of skull-based surgeries, and in particular to skull-based tumor. As you can see, as many do today, we started using segmentation, so diagram data derived 3D models, just to understand, just to preview the narrow corridors before doing the surgery. So this was the beginning, and we understood how many, as many are understanding today, that using 3D modeling can open your mind, can give you a new perspective, because when you are inside the head of your patient, you need to be able to change direction, to change trajectory, and to be oriented. And many times what we say to the young residents is, pay attention to use every day the neuronavigation, because this is addictive. This is a very huge risk, because at some point technology can abandon you. So there is a lot of technology in the OR, but pay attention to this. You need to start again from the tradition. I mean, you need to be able to do surgery as our professor, our old generations did. I mean, without technology, for what can be possible, obviously. I'm talking about, in this case, orientation technology, so neuronavigation. And in this case, we started applying, as you can see, simulation concept to preview the result of resections of tumors of the rocca vertuosa from a retrosigmoid root or a subtemporal root. This was just an exercise for the residents to understand which was the, for example, the possible effect of a residual in contact with the brainstem, or a possible effect of a residual in contact to the Merkel cave in this case. So are we able to do a second surgery? Are we able to use gamma knife or other technology? So this is just to think. And obviously training need to have a strong base of thinking, because many times what we say to our residents is that neurosurgery is just not cutting, dissecting. We need to think. We need to be ready to preview, but also to do good choices. And continuing with the example, with these applications, many times we had very impressive results preoperatively, having the preview of what was the result postoperatively. On the left, we had this homemade, let's say, program. We were playing with code. So with other residents, we started writing this code of this small application, and we started having the first previews of tumor. So it was very funny. It was interesting, but first of all, gave a new perspective. We can impact, we can change tradition. This is another example in the same period with Gian Antonio Spena, who is co-founder of Upsurgeon and was my mentor in the period. We started applying three-dimensional photogrammetry to intraoperative view. We didn't invent anything. We just applied photogrammetry to intraoperative views. We published something, and it was very interesting because there was a huge impact of the visual aspect. And very soon we understood that realism is crucial in training, is crucial in giving you a correct perspective in understanding. And we continued during the years applying the same concept to vascular neurosurgery, like in this case, as you can see, so previewing the position of head and necks, in case of, in this case, MCA aneurysms, many times using very basic tools like Blender. Blender is a completely open source and free access tool for three-dimensional modeling and all these kind of technologies. Just to say that today, technology is accessible. It's an open world. So if you have an access to internet, it's just, the limit is the sky, because everything is already available. So you need to be curious, you need to be constant, and this is the result. And in this case, we started using also 3D renderings to preview the possible orientation of aneurysms. As you can see here, there are two cases of MCA aneurysms. So different cases of length of the M1 segment, and different cases of different orientation of the neck. And according to the orientation, according to this feature, we started analyzing the difference and the impact of a subfrontal route or a pterional route, so more lateral route, to access the same aneurysms. The real impact of this was not just on the patients, by the way, because they were operated already many times. The impact was on the surgeons, the young neurosurgeons who approached this topic and started understanding these very difficult concepts. In these videos, for example, you can see how two residents, very young residents, are clipping an aneurysms. So after the mental exercise of understanding, the point is that everything finished. If you just use virtual realities, if you just use models, virtual models, everything finished there. What we need is to move our hands. We are surgeons. So I love technology. I love the virtual technology. I love all these things. But if we do not merge this with some, let's say, physical concrete step, is just a mental exercise. So what we need is to create opportunity for young residents to in this case, to clip an aneurysm, which is very limited in terms of training, obviously. So we started with this huge project, started also involving many institutions, because there was a problem. There is a cultural problem. So we needed to involve as many institutions as possible. So we started also, in this case, working with the key opinion leaders, in this case, like Professor Marco Censato here in Milan, one of the leaders of the vascular neurosurgery here in Europe. And having the support of the, let's say, the masters gave to us youngers, let's say, a huge motivation. We understood that with the right mindset, we could merge different generations on very important and special topics. So what about the sensitivity? We are trying to create hybrid teams with the surgeons, with the also anatomists on one side and technology. So developers, artists many times. So many times very talented artists coming from gaming or coming from cinema or coming from other environments. And this is the results after 5 years now. As you can see, we created very sophisticated ambience for microsurgical simulations or under the microscope. So we do a lot of courses using this technology without touching a cadaver. And by the way, there's no pathology into the cadavers. So this is another example of training under the microscope. We started now analyzing soft tissues to, as you can see, there's no brain, it's just tissues, to understand how we can merge everything with the let's say or two more topics and the issue of resections, the deep resection. So we are running now. All you can see is R&D, our experiment many times. And talking about pediatric, we are now going to release the first pediatric course very soon, next month. So these are cases of malformation, and there will be, for the first time, 45 cases on the table. So 30 residents coming from all over the world to operate the cranial stenosis. It's quite unique, because if you think there's no cadaver, I mean, that can be used for training in pediatrics. So we started this webinar from pediatrics. So it is crucial, because there's no, let's say, the training in that topic is very difficult. And this is how we are merging now virtual reality with the rest, with the physical. We are start doing this kind of design study. This is the first study that we are doing. We started analyzing and sensorizing the brains, and we started measuring the forces you put on the brain. We started analyzing what happened emotionally to the surgeon. So we started putting electrode to our colleagues to understand what happens to them. Why this? Because we need to understand that surgery is also emotional impact. When you have the rupture of an aneurysm, is a crazy moment, and you need to be ready to have the instinct to control your fear, and also to have to maintain, I mean, the control of the situation. And so emotion is crucial, and control over the emotion is crucial. So what we are trying to do is, how can we train people to have control on their emotions? So many times in these studies, we try to understand what happened to measuring parameters. We are working with many people in many groups around the globe also to understand the impact of realism in simulation, and the impact, obviously, of the sensorization of brain, sensorization of instruments, etc. So it is a very interesting topic, which is the future. We are pushing to new simulation in neurosurgery to the next level. For example, with the arachnoid, we are now in a very interesting period, because obviously many times when we do these courses around the globe, people are amazed, but at some point someone says, hey, but what about the arachnoid? So this is always this question is my nightmare. So with my group, we are running to deliver the first simulation of arachnoid. Obviously, anything can be done without scientific validation. So we are working now with the support of Harvard and Mass General Hospital for a very important validation study ongoing, that we are going to finish this study this month. We want to demonstrate what is useful is not just a simulator. The simulator is just a technology, and technology changes. What we want to demonstrate is a concept. The concept is, if we train people in a proper way, and this is a 6 weeks program of training, we can have differences. We can have an improvement in skills. So as you can see in this preliminary validation study, we are creating batteries to analyze the skills, the tasks of the students. And talking about, and I will conclude with this, talking about around the globe, what we are doing, we are, after 7 months of work, we opened this technology around the globe and we had an explosion. This slide is not updated. We are now at 70 countries around the globe. So there is a huge interest, obviously, from our community. And I am very amazed to see how there is participation from any generation, because learners love to learn, and my teachers love to teach. So obviously also the masters experiment the possibility to do courses in an hotel or wherever. So this is absolutely engaging and inspiring. And we also did a very important project in 2021, which is the Global Training Project 2021. Upsurgeon is as also a non-profit part of activity. We have a very huge, strong social commitment. So we started working with the World Federation of Neurosurgical Societies. I am part of the Young Neurosurgeons Forum, and we worked with the NIHR, and we did the first program, the first global training program in 2021, a calendar of 11 courses, where in LMICs we did the real courses without cadavers, and now we are publishing the first results. And the result has been incredible. The engagement during the courses has been total. And as you can see, young guys, young residents having the opportunity for the first time to do specific things. And in many times, for example, we created, thanks to Professor Najee Al-Abadi, the current president of WFNS, we started working with Professor Servadei, the past president, and now we are with Najee Al-Abadi. We did the first lab for simulation in Africa, in Morocco. So the permanent simulation lab for, let's say periodically, people from all over African regions go to Rabat to do training in a monthly basis. This is what we are doing together. And in many other countries, thanks, for example, to Ignatius Essien, we did a lot of courses in Cameroon, and we did courses in Ethiopia and in other countries. And interestingly, I put these slides here after the first ones, because in the same day we did exactly the same courses in very different places. What I want to say is that we are creating a community. We are creating a connection between the same generation of surgeons in very different places with different facilities. So the result is a community. And this is my view. I mean, we at this point, and I conclude, we need to continue working together to deliver not just the technology changes. We need to create engagement, we need to create progress, and we need to create hope for our patients, but also for our trainees. We need to create opportunities for them. So I really appreciate it when we go around the globe with these initiatives, to see that there are many initiatives of education around the globe. And when we go there, we try to merge with the others, with the other idea, with the other technology, even with the other companies, if there are other companies behind, and the result need to be understanding the values of what we are doing. Thank you very much.
Thank you very much, Professor Nicolosi. We can take comments from Professor Ashish Kumar.
Professor Nicolosi, that was an excellent presentation. Of course, I knew some parts of it because I was, as I said, I was talking to your team. But what I like in this simulation is the times, how many times you can do the same thing on the same patient, or on the same cadaver, or not cadaver, actually on the same model. And you know if you are in the right way, or you are doing in the right direction, or you're not going in the right direction. I wanted to ask if there is, in these models, if you have any kind of check for a surgeon or for a resident who is trying to clip an aneurysm, and if it's not adequately placed. Because I know if this is if suppose there is it depends on how you clip an aneurysm. Like you can leave a residual, you can leave a big residual, you can put a clip in an appropriate fashion. So just putting it on a model is okay. I'm saying, like, what is the next step? Do you have any sort of a check saying that, okay, this is not adequately placed and the system recognizes that? For example, I'll give you an example. In endovascular simulators, for example, by Mentis, when you are actually going through the catheters and the wires, it will rate your movements of the hands, movements of the wires and the catheters, and it will tell you, okay, this was probably dangerous. You did not do it properly. This is the percentage of error. Although they will reach where they have to reach with the catheters or the wires, but the way the wires are moving, that's hitting the wall, has high chances of arterial injury. So it gives you real-time feedback, and a residents can actually learn from, okay, this is how I started and this is how I ended after 5 attempts. So they actually see the improvement during the same course, that their skills have improved and their chances of errors have come down. So when I see this up, like in open vascular simulators, I just wanted to ask if you are if there's any sort of a check, or if there's any sort of a self-assessment module on which, if a resident has started the process at the first instance, and after 5 attempts, whether he has improved or not, how to know that?
Thank you very much for this very insightful question. Absolutely, you centered the point. There's nothing it's not useful if you don't understand if you did the error or not, obviously. I want to start saying that working in this project gave us the opportunity to understand that there is a huge problem. There is a huge number of people, metaphorically, who cannot walk. And before talking about training people to run, we need to create a basis of people that can walk first. So we need to train people in the basic things. What I want to say is that when we do the courses, many times the issue is not if the guys put the clip in the correct way or not. Many times the issue is that they are still having problems in using the microscope or understanding how to use the clip holder. I mean, very, very basic stuff. So many times we say we are ready to train people to do this, but first of all, we see that many still need to understand from basics. So what we are trying to do is obviously to create a moment for runners, but also a basis for walkers. And to say this, the strategy to diffuse the technology, first of all, was a matter of acceptability. There is an acceptability, an issue of acceptability. I mean, we need that faculties around the globe accepted to open the door. To do this, the strategy was, hey guys, let's talk, let's work together. And what I want to say is that when we do the courses, we want that the local faculties, all the international faculties, are there to give one by one suggestions. I mean, we still believe that also if we improve the technology, and by the way, we are improving, and I will answer also to that. Also, if we improve the technology, and also if we create a super technology that give you all the feedbacks, we want the contact of the teacher and the learner. We want the mentorship. We want to create a super environment for a good and traditional mentorship. So for the first time, just to answer to your question, we have seen masters saying to learners, hey, you didn't put the clip in a very good position. You need to change it. Try to imagine if this was possible on a patient. This doesn't exist on a patient. The learning on a patient is, I see how to put a clip, but the hands are not mine, are the hands of the masters in the moment. And I just listening. So first thing, yes, we are working on feedbacks, trying to create connections with masters. Of course, we are also working on technologies where the augmented reality give you feedbacks, the bleeding can happen. For example, tumors. We are working with tumors, we are creating reusable tumors to have an orientation, and then disposable tumors where you destroy everything. For example, the clip of the aneurysm has been done in the videos. on a reusable aneurysm. So you can do this forever. You do not destroy it. If you destroy the simulator, there's an issue. You need to replace it. So if we want to do this many, many times in LMICs, for example, if we destroy the simulator, it's the equivalent of a cadaver. We need to create smart solutions to provide the possibility to do something many times. Of course, at some point we need to say, okay, all these people started walking, clipping as a basics on a super infinite aneurysms. At some point, one of them say, okay, I now am able to walk, I need to run. Please give me an aneurysm where I can also create a rupture if I am too rude. So this is what we are doing. But let's say we have, and I finish, a wider approach to education where we say, okay, let's democratize first. So first of all, basics for all of us. And then obviously the moment of super perfection is in specific courses that we do, many times also merged with cadavers, by the way. I don't know if I answered to your questions.
No. You answered it correctly. I've seen this, and I will reiterate once more that, short of cadavers, like there was nothing on which a resident can train. And imagine if somebody's sitting remotely, as you saw actually in those slides, like there was a course in Cameroon. I know Ignatius has been doing great work there, but like there are other parts of the world where they don't have access, and this doesn't need an institutional access. This can be an individual access. So a person can just take it and try to practice. So as you said, like, first you have to walk before you run. So this is a very good, understanding of the basics, how to dissect, how to dissect the arachnoid, for example, as you said. So I think this is an excellent medium for surgeons across the world, and it's going to pick up nicely in next few years. What I was talking about is probably when you expect certain things, then you start to expect something more. So in future, probably, as you said, you were also observing the heart rate and the physiological parameters of the surgeon who is doing the surgery. So that's something in the future, right?
Let me say something about this. Many times older generations say, oh, it is impossible to learn this kind of surgery if you don't do specific stuff. I don't know. We are more democratic. We say anyone can do this, anyone can learn. And this is one of the bases of the engagement also through social media. The young neurosurgeons say, I love this because they say that I can do that. And this is what we are trying to say. So anyone can do. What you say is normal because when we do courses, the residents say, oh, I've never used a clip holder. I never put the clip anywhere. Once they put the clip 2, 3, 4 times, they say, hey, here seems easier, obviously. It was not that incredible stuff, can be done probably also on the patients. What's next? So this is what I say. Also during the courses, walkers start saying, when do we start running? So just to answer, it's a normalist thing. So anyone want to run. We are here not just to walk. We want to become neurosurgeons and we want to do the best thing possible. So obviously we are hungry to do more. So I agree with you. This is absolutely a nice instinct.
Oh, thank you so much. This is really excellent innovation in the field of neurosurgery, and it's going to be really popular in some time. As I said, in Toronto, we are having this in this September, and they are at par with the endovascular simulators. Before, there was either cadavers or there was nothing. So this fills the gap in between perfectly. So thank you so much for your thinking.
Thank you very much to you and to all of you.
Thank you. Thank
you
very much.
I would ask the panel if they have questions. Dr. Raja?
Thank you very much. I would like to comment that I have been using simulators since a long time when we were in Japan, and they're by the Keslex company, which you may be knowing that they have the vascular. In fact, I am using the same vessel given to me by Professor Takizawa, around 1 meter long vessel, which I still use for anastomosis, cut pieces and then anastomosis. I've been using that same vessel. And also there have been so many aneurysm rupture models there already available in Japan, which I had mentioned it once in one of the webinars. the AMC aneurysm rupture models and IC aneurysm rupture models, and this the mentors who are there like to guide us were like Professor Kenta Omori and legends like that, and they really can help us to put a clip like what is the best clip in which of the aneurysms. Like the clip he uses for MC aneurysms is fixed. It is a straight fenestrated right angle or a right angle fenestrated and straight. These are the two clips which give you the best configuration for an MC aneurysm according to him, and I still follow his principles in real patients whenever I clip the MC aneurysms. And of course it is, as I said, as you also mentioned, that rupture aneurysm is a like you have to have it in you to mitigate the situation. So I think these simulators are one of the best ways. I would like to ask Professor Nichols if he has ever planned on moving this upsurgeon to other body parts also, or exclusively is it for neurosurgery?
To be honest, thank you for this question. Yes, absolutely yes. Neurosurgery is a niche, it's very small. And the same logic, we are applying the same logic to several other disciplines. We are working now with the spine surgery, with the plastic surgery, general surgery, and all the rest. Obviously, my talk was not about upsurgeon, it was about the concept. So I didn't show anything about that. But yes, we are working with plastic surgeons around the globe. We are doing many other things. The concept is always the same, and the problems of residents in the other disciplines are absolutely the same of us in neurosurgery. They do not have access to practice or chances to do errors. So yes, this is absolutely our goal.
Thank you very much. We consider having an association with you on the when our ACNS real workshops happen. We look forward to have an association and organize a conference with you, of course. I would like to ask my co-host Liu Bun Singh, any questions?
Yeah, thanks, Raja. Thanks, Professor Nicholas, for a very nice presentation. I just want to bring your attention to some live cadaveric model by Professor Abbott from Little Rock. So he bring pulsatile aneurysm in cadaver. He call it live cadaver. So would that be the future in your model, where you get a live pulsating aneurysm in your model? And especially AVM model is very depending on circulation to decide which one is vein, which one is artery. My second question, in model, the problem is sometimes the placement, the position of the model will not be real in the real life. You can operate from every angle, but in the real life, there's a body in between your head and the surgeon. So is that part of an important determination in your model, how the surgeon should put the model and how the surgeon should be seated? My last question, Professor, regarding now we're going towards the era retractorless, where gravity is very important component in neurosurgery. Would your model in the future will take effect of gravity to reduce the use of brain retractor in your model? Thank you, Professor.
Yes. I want to answer to all your questions. So the first one was about cadaver and let's say live cadaver. I love this kind of innovations, and what I still say is that we need to merge with any good idea in training. So what I say is it's amazing, it's inspiring, it is difficult to be repeated everywhere, but that is the reason. So what I say, I repeat, we need to use also the cadavers in any way possible. We need, but the problem is that you can do that activity not all the every day, not every week. You can do a couple of times. Probably the residents of that centers can do this every day, but many others not. So the point is, what can we do in the between? We pretend to play the piano, playing a piano once per year. This is absolutely crazy. If you talk with a pianist and you say, hey, what do you do every day? And he says, I train on the piano. And we need to do the same if we want to reach the same level or we do many Aneurysm patients and we spend a lot of years. And about positioning, yes, our technology, thank you for this, because many times in neurosurgery, positioning concepts are scotomized. I mean, people do not understand the importance many times of preparing properly the patient before surgery. So you need to create a tailored approach, and the variability or the variables are where the pathology is, where which position you choose for your patient, and then which is the entry point. So at some point, you block everything with your Mayfield, and the only issue is where you open. And when you did it, if you did errors in the first two steps, it's all yours. It's a problem of you, and nothing can be changed at that point. So many times you operate like this because you did an error in the positioning, or you use the bed in so you ask for the nurses, can you say me if you immobilize the patient properly, because I need to tilt all the bed because I did a bad positioning, etc. So yes, the technology we are using provides you the possibility to use virtual reality to understand how the entire head is positioned. Then physically, you have a small area, a small volume, which is the box, but you needed to see an entire head. So this is the low-cost concept. We don't need to have the entire head to do a small hole here and do an approach to middle cranial fossa, for example. So yes, positioning is something we started with, because residents, before touching cadavers, before touching patients, before doing simulation, need to understand what to do, how to prepare the patient, how to position, because actually this is what they do during their residency. They do a lot of positioning and craniotomies, and then they see someone else doing something for years, and then they close. This is what we do. Third question about retractorless. This is an incredible question, because in many courses we have, for example, talking about the same model, the model of aneurysms, and sometimes we have also the basilar tip aneurysm. I understand that it is not a surgical issue now, because we use embolization for this kind of location. But many times we challenge residents to say, okay, you have a pterional, a white pterional, try to identify the basilar tip aneurysms. And many times, I've seen many of them saying, I don't see that. This is impossible. It is absolutely impossible. What happened is that sometimes, given that the box has a spheric part, we move under the microscope. While we are looking at the middle fossa, we start moving the box under the microscope. And at some point, for some degree, we identify the basilar tip. So they understand that small degrees, small amount of degrees, small changes in the positioning give you a trajectory without using retractors. I mean, using just the Sylvian fissure. So here is another point. You did a very good questions which are connected, positioning and retractorless, because if you position properly, you may have less need of retractors. So it's up to you. It's up to you plan the trajectory. And obviously, it's also up to you in terms of preparation of the corridor, if you identify the distance first. I mean, these are basics.
Thank you very much.
That was an interesting answer. Any questions from you, Ben?
Yes, thank you for the sharing, Professor. And I'm Ben from Hong Kong. So I really echo your the sharing and thank you for your understanding for the difficulties for the young neurosurgeon to train up the skills. And I very like your curve, the curve with daily practice, simulation, and also the practice in OR. I think is absolutely right. And we need to practice every day. Sometimes as a young neurosurgeon, I feel that the difficulty would be due to your tight work duty schedule, so that you don't get enough time for the daily practice. And yes, we can attend courses, but as you know, the COVID is still prevailing, so we cannot attend the cadaver courses in the meantime, at least for me. And my way of doing this is to get a microscope at home, so that I could practice on all the microsurgical skills. So the question that I want to raise is that I'm absolutely impressed by the models because I'm following your pages, the IG posts. So do you have, may I ask for the cost or for the model, is it there will there be a commercially available version or a simplified version so that we could easily get it at home so that we could practice on ourselves? Will there be such kind of product soon? And also another question would be, is there a plan to make, for example, a patient specific model by your company so that for example, some difficult aneurysm or difficult tumors that you could get some model to practice on it first before the real OT? Thank you so much for your sharing. Yeah.
Thank you for your questions. First of all, I am just the scientific part of the surgeon, so I don't talk about these kind of aspects. But what I want to say is that everything has been built on the concept that anyone need to access this. So anyone need to have the freedom also to invest on himself. So what we created was, first of all, something accessible and public. So when we talk about accessibility and how much it costs, generally everything is public on our website. And this is to say that we recognize the value of making the prices public, because many times many technologies don't do that. They simply say, send an email and I will do a quotation. And many times the pricing absolutely not affordable for a user, so a single user. Many times are for industries or for hospitals. So we are talking about hundreds of dollars, not thousands of dollars. So just to give you a measure. So anytime anyone can access. Many times we understand that this is not for anyone, but also many times people access the courses we do. So many times we do the rentings or the courses, which are very cheap and accessible. And many times during a course with cadavers, you spend $1,500 and you do 2-3 craniotomies. In our courses, you spend much less than $1,000, and you do 30-40 craniotomies, a lot of tumors, a lot of bypass. It's just up to you. Many times residents do skip the lunch just to have more time to train during the courses. So just to say that the accessibility is the key. To be honest, what we do is to open doors to other disciplines which are bigger, where there is a huge possibility and a huge market, let's say. But in neurosurgery, we started as neurosurgeons in neurosurgery, and we have a mission in neurosurgery. So everything is accessible. And of course, as I said in the beginning, and I will conclude, we are working with other disciplines, and we survive thanks to the other disciplines because neurosurgery is very small. And by the way, in neurosurgery, we have a mission to change and to impact on that. So our, let's say, first goal was to impact on the scientific community. But of course, we have 40 professionals in upsurgeon working. So we work also with other disciplines, let's say, which have different numbers also in terms of requests.
Thank you so much.
Thank you very much. Yes, Professor Ashish, we can conclude with your remarks.
Yes, so it was an excellent session, and I think all those who have been on this webinar, they must have benefited tremendously. And I was just talking to Dr. Ben here that the model is such that an individual can practice at home. They don't need microscope even, like they'll provide loops and instruments. So it will be very, very useful for many people across the world, especially those who are from like the LMIC group, and they will be benefited tremendously in terms of their hand skills, in terms of visualization of the operative field. And as well as now they have a model for transsphenoidal surgery. So, now they are going into endoscopic skull-based surgery models as well. So I think this is something which will be a game changer in neurosurgical education. And I thank Professor Nicolsi to take that, in initiating this this project, and that has benefited many across the world. So with that, Professor Raja and Professor Liu, thank you so much for having us today.
Thank you very much. It was indeed a wonderful session, And I'll wind this up officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Professor Araki Takashi and Professor Federico Nicolsi, as well as the chairs, Professor Thomas Nakagawa and Professor Ashish Kumar, for the time and support for the ACNS webinars. I would like to express my sincere thanks to Professor Shubin for broadcasting this on the WeChat channel. And today we had around 550 people who had joined us live. A special thanks to my co-host Liu Bun Seng for joining him today. So until we all meet on the 6th of April, it is bye-bye from all of us. Thank you very much for joining.